Lawrence Dorr is from California, America, orthopedic surgeon, runs the Institute of Arthritis. He founded Operation Walk in 1994 with a view of, as the name suggests, Operation Walk, to make people walk again who were disabled with hip and knee arthritis. These patients belong to developing countries, poor, who couldn't afford. So he founded, and then he collected donations. He collected people, volunteers, physicians, anesthetists, orthopedic surgeons, nurses, physiotherapy. So he has made a big team there, and then we understand now that even up to 4 trips a year in different countries they would go. But they do work that wherever they want to go, there is some counterpart or some link there who to give feedback, and then they want to see that what sort of cases are collected, and some counterpart will be doing some post-operative care and facilitate Operation Walk team going there. So it is a medical organization, private, non-profiting, and aim is to get rid of pain, make the people walk again, and make them to earn their bread again, supporting their families. So it has been doing very good job all around the countries, including Nepal twice. So really it was a good opportunity for us who wanted to be involved. So it was when Mr. McMinn said, team, let's go, come along, and it was really very sort of good opportunity to contribute to humankind, which we were good at. And we really enjoyed it.
When we first found out that we were going to Vietnam, that was when the real work needed to take place. So probably for about 6 months plus prior to us going, we had to look at everything we did from a surgical, pre and post-operative, anaesthetic point of view, and then approach every company that encompassed anything that we currently used to see if they would donate anything. So we believed that even though we were going to operate on impoverished people, that we should offer them exactly the same service that we offer them in our own place of work here in Birmingham. So basically that meant we wanted to reciprocate, everything that we used here was everything we were going to be using there. So after all the initial organising, we had to arrange separate shipment dates for a lot of our stuff to go out, because we were currently using, say, some instruments and things here that we wanted to take with us. So we had to arrange separate shipping. So that was a bit worrying that that shipment was actually going to be there ready for us to use and cleared by customs by the time we were ready to operate. But in fact, when we got there, everything worked out absolutely fine. Shipments were cleared probably the day before we started operating. So we were able to use a bit of free time that we'd had on arriving to sort of acclimatise we used it as a team to unpack all the boxes, make sure everything was in order. And in fact, we'd done quite a good job. We didn't really run out of anything, really.
Well, as a preparation, we had all the patients to be operated, X-rays sent to us, I think a few months ago. Before.
How many?
I think there were 69 X-rays or something like that. And all those X-rays of the hips I templated because we knew that Smith and Nephew Orthopedic were going to donate total hip replacement or hip resurfacing implants if needed be. So they were all templated much before and then checked by Mr. McMinn. We operated on 19 joints, all hips in 16 patients, and 3 were both bilateral, both hips. And the patients were aged pretty young, from 25 years of age till 69. And the disease pattern there were different. There were avian of 13 cases, developmental dysplasia 2 cases, 1 bullet injuries, 1 old fracture neck of femur non-union, 1 perthes, and 1 old trauma. These were the diagnosis. 4 patients we could do less intrusive operation, Birmingham mid-head resection, and rest of the operations were total hip replacement. So obviously 4 patients had the benefit of less intrusive, and if they needed any total hip replacement later in life, it can be relatively easily revised. Other operations, hip replacement included 6 patients with dysplasia cup, screws, and acetabular bone grafting. And Vietnamese patients, we knew from their side they would have a smaller femoral canal. So in 3 patients we had to use a smaller femoral component. Specifically, we found out at that time belonged to SL Plus Japan, which is mostly used in Japanese sort of population. And other were metal on metal total hip replacement using this combination, or total hip replacement using ceramic head, cross-linked polyethylene, and reflection cup.